Hello, everyone, and welcome to our program this afternoon, Convergence, the Sum of Us. I am Marvell Terry II, founder of the Red Door Foundation and the Saving Ourselves Symposium, also known as SOS. Our theme this year is collective power and collective solutions. This notion or this ideal or even this theme, because you know I love a good theme for a conference, is not new to us. We became very familiar with this concept of collective power and collective solutions when we were children. They were all superheroes in our lives, but when they combined their efforts and their powers with one another, they were a great force. Some of you all are superheroes. You come to this space with your power in hopes of going back home and finding a solution. Today, we are calling upon the power of the sum of us. Many of us are community members living with HIV and HIV negative. We're community workers. We're outreach workers. We're prevention specialists. We're early intervention specialists. We are case managers and healthcare providers. Some of us are policymakers and policy advocates. All of us have a power, a unique gift, a specialty despite comparison in CBOs and ASOs of Black gay men across this country. Each one of us are very unique in the ability we have to mobilize our community. We have the ability to leverage knowledge and skills to accomplish great things. Our focus in today's program looks at how we converge our talents. How do we put our gifts together? How do we do our creative mojo that we have and create something very powerful? How do we identify priorities and actions needed to ensure access to HIV prevention, care, and treatment for Black gay men across this country? How do we begin to build on learnings from our own movement and other social justice advocacy efforts? And then finally, how do we begin to recognize new opportunities for collective action and solutions? Each one of our speakers today all have stories and insights to share about their work and their advocacy on behalf of those who are living with HIV and at risk for HIV. Each will show us how the sum of us can rise to our collective power. Joining us today, we have Greg Millett, Vice President and Director of Public Policy for amfAR. We have Dr. Roberta Laguerre-Frederique, Director of Prevention and Outreach Services for the Dorothy Mann Center for Pediatric and Adolescent HIV. And then we have Justin T. Rush, Director of Public Policy for the True Colors Fund. So please welcome our first superhero today, Greg Millett.
Good afternoon. So I'm really excited to be here today. I wanted to thank Marvell Terry as well as everybody who's responsible for pulling together this conference. It really is an honor to be here and to see how SOS keeps getting better and better each year. And really is a testament to all of you for coming out and supporting this type of work and for this type of activity. So I want to talk a little bit about how far we've come in terms of the HIV/AIDS epidemic, and to also talk a little bit about what more we need to do, and then the importance of doing all of this together. So I have a secret to tell you. I am proud that as of next year, I'm going to turn 50. Come on, 50. Very happy about turning 50, let me tell you. I was a teen in the 80s. I'm not sure how many other people in here remember the 80s. Okay, hold on. I'm not talking about y'all who were born in the 80s. How many of you actually remember the 80s? There we go. Okay, y'all are my people. There we go. Well, in the 80s, I grew up in New York City. I grew up in Greenwich Village, and my dad worked there, where it was basically the hub of the gay community. And from as long as I can remember, I remember going into Greenwich Village and watching my dad while he was at the hospital. And every time that I'd walk around in the village with him, I would see lots of gay men coming in and out and in different places. And from the time that I was a little kid, I would look at a lot of those men and I would say, I'm just like them. I didn't know what it was, but I knew that I was just like them. So imagine how frightening it was for a child of middle school age by the time the mid-'80s came around to see young men, some of whom were no more than 5 years older than I was, who were sick and dying from HIV. New York City was awash in death. And there was also an awful lot of anger. But people channeled that anger into action. And the government, unfortunately, did very little. But what that did mean was that we could all come together as a community to do what we knew needed to get done. So I was eager to do my part. I volunteered for Gay Men's Health Crisis in the mid-'80s, teaching Black and Latino men about HIV prevention. I also joined ACT UP a little bit later on and fell into a crew of Black activists who we charitably called ourselves Act Black. So we all learned to act up, to fight back, to fight AIDS. And thankfully, 30 years later, a lot of these efforts have been incredibly effective. All of the work that the sum of us, every one of us in this room have done over the past 30 years have brought us some amazing gains in the domestic HIV/AIDS epidemic. I mean, you guys have seen the statistics that CDC's released. People are not dying from AIDS at the rate that we used to. In fact, death rates have declined incredibly dramatically for HIV in the United States. Today, people are living longer and healthier lives, and that's something that we need to be thankful for. Other things that we need to be thankful for as well is that for a long time, we've had a plateau in new infections that were taking place in the United States. We never thought that they were ever going to go down. But now we know that over the past 10 years that we're actually seeing a decrease in new infections in the US, a 20% decrease in new infections. And the other good news as well is that the rates of new infections among African American women, as well as injection drug users, have been plummeting. That is fantastic news. And that is something that we have to continue to build upon and make sure that that continues within our communities. But unfortunately, not everyone is benefiting from the accomplishments that have been made in the domestic HIV/AIDS epidemic. We still know that new infections among gay men overall have remained level, and that Black MSM still comprise the largest number of new infections, both in the Black community as well as in the gay community. We also know that new infections are increasing for Latino gay men, as well as gay men between the ages of 25 and 34. We're still more likely to die from HIV. And too few of us overall know about or even have consistent access to pre-exposure prophylaxis and other prevention tools. And all of this is taking place against the backdrop of a really difficult and crazy political environment. Honestly, if you asked me if we were on the way to end the HIV/AIDS epidemic among Black MSM 5 years ago when I was still working in the Obama White House, I would have looked at all of y'all and I said confidently, absolutely, yes, we're gonna do it. We had a national HIV/AIDS strategy that explicitly made Black MSM and the Black community a priority. We had the Affordable Care Act, which granted insurance to more Americans than ever before in the United States. We had LGBT rights that were undergoing a sea change in terms of unprecedented expansion in courts as well as in federal policies. And we had new and exciting tools for PrEP as well as treatment as prevention to finally beat back the epidemic. Well, a lot can change in 5 years, huh? In fact, a lot has changed since January. Because we are nowhere near where we thought any of us were going to be in terms of the domestic HIV/AIDS epidemic 5 years ago. Now, more than ever, we have to come together as a community and draw upon our collective strength to protect the advances that have been made and to fight for more. So what can we do? Well, there's a lot of things that we all need to be able to do. There's a new federal budget that's been coming out by the Trump White House and others, where there's been drastic cuts for CDC, for National Institutes of Health, for HRSA and HHS. Who do you think those cuts are going to affect? It's certainly going to affect African Americans. It's going to affect gay men. It's going to affect many communities in the South. These are not good news for us. We're going to have to fight those budget cuts. There are also continued efforts to repeal and replace the Affordable Care Act. And we know that there's a possible Senate vote that's going to be taking place as early as this month to repeal ACA. ACA reform hurts most of us in this room the most. We've got to make sure that we fight those efforts and to make sure that as many people living with HIV or at risk for HIV continue to be covered by insurance. We must also ensure that cuts to research do not translate into less work or targeting for African Americans, for MSM, and other communities at risk for HIV. And we also have to make sure that the research that gets cut or does not get cut does not curtail our progress in biomedical advances such as treatment as prevention, PrEP, or even PEP. And above all, we need to make sure that we preserve the combination prevention toolkit that we have pulled together, looking at behavioral, structural, as well as biomedical interventions to keep our communities safe from HIV. And last, we have to keep a laser focus on the National HIV/AIDS Strategy and make sure that it continues to guide our goals to getting to where we need to be for the domestic HIV/AIDS epidemic. So some of you might be asking, how do we do this? Well, there's a couple of things that I have some thoughts about that I'd like to share. The first is we are most effective when we're credible. Let me say that one more time. We are most effective when we're credible. And credibility starts with being educated about how things work. We need to be fluent in science and in policy. We have to be fluent in science because it allows us to engage with scientific experts and to let them know where the gaps are in some of the science that could affect our lives and our communities' lives. And we also need to understand how government works, because how policy is made allows us to engage with policymakers and to move our agenda forward. Other things that we need to do as well is we need to understand how the federal budget and processing works. There's a lot of times when I would hear from advocates, well, if there are cuts in HHS in this department, that's all right, because that means that we can move that money over to HIV. And I'm like, it doesn't work like that. It's not like our own personal budgets where we can move things around at home. The federal government is a completely different thing. And that's something that we have to understand exactly how that budgeting process works. We have to educate ourselves as well about HIV medication development and fight for new and existing effective technologies. These have been some of the game changers that have taken place in our community. And we have to demand access to new clinical trials and show up to make sure that effective medications get through FDA approval. We also have to get to know how the government works and where do we apply leverage to get things done. This is something that some of the older activists did incredibly well, especially ACT UP. ACT UP was so successful because they not only had an outside game that we all saw in terms of their activism, but they also had an inside game where they met privately with Dr. Fauci, with the National Institutes of Health, with CDC, FDA, and other federal officials to make sure that policies were passed that benefited people living with HIV or were affected by HIV. We have to do exactly the same things. We also have to develop relationships with people inside and outside of government. And one thing that I've learned from living in Washington, D.C. the last 8 years, and then prior to that, living in the Deep South for 15 years, is that having relationships with the right people make the difference. That's something that we absolutely have to cultivate. We have not the luxury to think that just because someone is a Republican or a Democrat, that we have nothing in common, that we can't work together. We can't allow ourselves to think that just because somebody is an evangelical or religious, and we may not be, that we have no commonalities between us. I'm here to tell you that I have found friendships in the strangest places. And these friends have been some of the most effective and the most important links that I have ever had for some of the advocacy that I've done. So we need to make sure that we continue to make some of those linkages. So I guess my main message for all of you today is that we can't only act up, but we have to show up. You can't have one without the other. Acting up is easy when we have all the cameras and the journalists and everybody else all in front of us. And when you basically want to show out. And you all know how we do. We like to show out. But showing up is hard because that requires the real work. It's the work that takes place in the background to really move the process along. We have to do more showing up. We have to show up for the Ryan White and state HIV planning processes. We have to show up to support sex education in our schools. We have to show up in grad school and add to the small number of Black scientists devoted and engaged in the fight against HIV. We have to show up to guard against the budget cuts to NIH, to CDC, Ryan White, HOPWA. If you're not doing your job on trying to hold back these budget cuts, then you're not involved in this fight. We have to show up to state legislators, to Congress in DC, and advocate for our own rights. Heck, we have to show up and just run for Congress and city councils on our own. Last, we have to show up and support our allies in the struggle against HIV. There are so many communities right now that are under attack. When it's women and reproductive rights, whether or not it's transgender women and some of their rights that are under neglect with the Supreme Court case that's coming up, whether it's Latino communities and other immigrants that are being maligned constantly in the press, or if we're even thinking about our brothers and sisters who are suffering under the opioid epidemic, who are also at risk for HIV, we're gonna have to show up for all those communities as well. We can't do this alone. It is about the sum of us. So before I close, let me thank members of our community who always show up. The first I want to thank is Linda Villarosa for showing up and documenting our lives with compassion and love that we rarely see in the media. I want to thank Marvell Terry. Thank you for showing up and helping to groom the next generation of Black gay leaders. Thank you, Cedric Sturdivant, for showing up here in Jackson and refusing to give up on any of those that many others would prefer to forget. Thank you, Daniel Driffin, for showing confidently and with so much grace how Black gay men with HIV can live our lives. So, what are we going to do? What are we going to do? Tell me, are we going to show up? Yes. What are we going to do? Show up. One last time, what are we going to do? Show up. Let's show up. Next, I'd like to introduce Roberta Laguerre-Frederique.
Good afternoon, everyone. I am so happy to be here today and so happy to hear Greg's spot-on insights. I am so energized, really, by the knowledge, experience, and promise in this room. It makes me so really hopeful about the tough challenges we face. I am Roberta Laguerre-Frederique, and I have had the great pleasure, I'm a general pediatrician, and I've had the great pleasure of working at the Dorothy Mann Center for Pediatric and Adolescent HIV at St. Christopher's Hospital for Children in Philly for the last 14 years. At our site, we take care of HIV-positive children and youth, birth to 24 years of age. Today, most of the new patients walking through our doors were not born with HIV, as you know. They are teens and young adults who've been infected with HIV through sex. And greater than 90% or over 90% of my patients are young Black men who have sex with men. We provide at our site routine HIV testing for all patients over the age of 13, regardless of risk, as part of their well child visits, and we're really proud of that. It ensures the earliest possible diagnosis for the youth from the communities that we serve. We also offer HIV treatment to all of our HIV positive patients as early as we possibly can per our DHHS guidelines. And we also now have the ability to offer HIV prevention services for both our HIV positive as well as our HIV negative patients. Today, we have biomedical interventions for both HIV treatment and prevention. HIV medicines used for HIV positive folks to treat their virus, but also to prevent the transmission of HIV to others. PrEP, as you all know, pre-exposure prophylaxis, involves taking medicines daily to prevent the acquisition of HIV through sex. And when people are on medicines to prevent HIV, they need to have regular HIV testing and close monitoring by a medical provider. And no question, PrEP has to be used in conjunction with other behavioral and structural prevention strategies to optimize prevention. PEP, post-exposure prophylaxis, taking medicines within 72 hours of a high-risk sexual encounter to prevent HIV seroconversion. And TASC, last but not least, TASC, which has been particularly excited for me as a pediatrician and HIV provider to see over the years, HIV positive folks taking their medications, shutting down the viral load in the blood and the genital tissues, and substantially reducing the risk of transmitting HIV infection to their partners. We are a small site at St. Christopher's, but 2 months ago, HRSA paid us a visit because of our very high rates of HIV care engagement and sustained viral suppression among our very vulnerable patients. It was really exciting to share those insights with HRSA, but I am particularly excited to share our insights with you all in this room. Our patients, young people of color, as many of you know, live in a world that demonstrates that Black and brown bodies have no value. Young men of color who are identified as same-sex attracted are often viciously marginalized by society as a large, but also within their own communities, schools, churches, and painfully so, even within their own families and homes. Managing HIV risk among young Black MSM has been a particularly daunting task for us at St. Christopher's. Countless times before we meet them, our patients regularly endure statements like, you probably already have HIV. It's only a matter of time before you get HIV. AIDS is what you get for being gay. You can have God or gay, but not both. It is therefore no surprise that Black men who have sex with men continue to be particularly vulnerable to HIV infection. They are less likely to be diagnosed early, less likely to be on PrEP, less likely to be engaged in HIV care, less likely to access and adhere to ART therapy, less likely to be virologically suppressed. In this climate, make no mistake, when a young Black man who has sex with men seeks care, they have to be brave. They essentially have to reject the shopped around notion that their lives are not worth saving, not worth protecting. This rejection is bold, yes, but it is often an anxious rejection. And in our patients' darkest moments, it becomes a question. Is my life worth protecting? Is my life worth saving? These are questions that no one should have to ask, ever. A couple of years ago, it became painfully clear to us and troubling to us that despite our best efforts, our patients were not achieving the health outcomes that really said that their lives mattered. When we looked at our patients' lower rates of HIV care engagement and viral suppression, we knew that a cold, hard examination of our process was really in order. And when we really did look at ourselves in the mirror, we saw that our approach was not working and that we had to do better. And while we had amassed a wealth of information about potential barriers to HIV treatment and care for Black MSM, we were obviously not putting this information to good use. Our turning point came when we recognized what I've already mentioned. Our patients are coming into care with some ambivalence about their very self-worth. And our process of intake and engagement inadequately addressed this underlying conflict. and unintentionally, in some instances, reinforced our patient's self-doubt. That was particularly difficult for our team to face and acknowledge, but it was game-changing for us, right? And at that point, we focused on changing our patient engagement process, and in particular, our intake process. We understood at this point, finally, that we had one opportunity, that first encounter with our patient was make or break. To that end, our program delivers on-demand, open access patient care. This is a model of healthcare service delivery that responds immediately to the needs of the patient when they come in for HIV testing, prevention, care, and treatment. Patients are never asked to wait, schedule, or delay their care. We change our plans to meet theirs. Staff are welcoming and demonstrate an appreciation for that patient's brave step to seek care in such a difficult climate. Healthcare and support services are consolidated into one visit to accommodate their needs, not ours. Today, our actions say in every way, yes, your life is important. Imagine a young black man, a young black MSM. He is 19 years old, and we'll call him Terrence. It's 10:25, and he's heard from his family doctor, the doctor, by the way, who helped his parents to have him committed to a psych facility when he was coming out at the age of 16. He's heard from this doctor that his HIV test is positive. Terrence is so devastated that he's practically mute. The doctor calls our office to help him to make an appointment. We respond that we'll see him today, now, if he's willing. We offer to send him a taxi if he can't get here on his own. He refuses the taxi. He's just not sure he'll come in today. Terrence is reeling, and he's really unsure of what he's going to do. He is feeling the disdain of the doctor who made sure to utter, "It was only a matter of time before you got HIV." As he leaves the doctor's office, he's feeling like he just can't deal with this today, and he'll put off the appointment. Something inside of him, though, wills him to come to our office. He walks through our doors and is greeted by Evelyn, one of our front desk staff for about 20 years. She identifies him as new immediately, and with a warm smile, she says, "Welcome." And she has the following interaction. "What is your name, sweetie?" "Terrence." "Oh, Terrence, we're so glad you made it. Dr. Laguerre has been looking out for you. I'll get her now." Terrence is greeted by me and one of our social workers, and he's promptly brought back into a room. We'll do the paperwork later. He is warmly welcomed by both of us. We acknowledge that it must have been so difficult for him to come in today, but that his arrival demonstrates that he knows his value. We express to him in several ways that we can that we have stopped everything to see him today because we too believe in his life's value. Terrence is tearful as we begin to talk. As we meet, Terrence is constructing a narrative about what HIV infection is going to mean in his life. And in this very important encounter, we are allowed the privilege, the crucial, critical opportunity to help contribute to the construction of this narrative. Our 3-hour visit culminates in our presentation of the goals of ARV therapy. You see here the DHHS guidelines. It clearly guides all HIV providers in terms of starting patients on HIV treatment. Our patients, though, they need to hear in clear language what achieving these goals is going to mean in their day-to-day lives. We always know the moment when the patient has heard enough because, like Terrence, they ask us to start ARV therapy before we can offer it. It is incredibly humbling to witness a patient regaining control over their lives hours after they have heard that their HIV test is positive. We have created a rapport with Terrence that engages him, He returns to clinic at 1, 2, and 4-week follow-up appointments where we discuss issues he may be having with adherence and monitor his viral load closely. We know through the DHHS treatment guidelines that when patients are adherent and they don't have resistance to the components of their regimen, that they can achieve an undetectable viral load between 8 and 24 weeks. During the follow-up visits, we work on various issues with Terrence, including sexual safety, housing, school reentry, and mental health, all of which began on the first encounter. Our on-demand open access approach to our patient care has dramatically improved the quality and impact of our intake process and our patients' health outcomes. Our patients now are more likely to remain engaged in HIV care, almost universally choose to start antiretroviral therapy on the day of diagnosis or shortly thereafter, and are more likely to achieve an undetectable viral load and maintain it. When HRSA asked us what I thought was critical to our patients' success, I said our on-demand open access model to HIV prevention and treatment services. When a patient walks in, their request for care is our immediate priority. Our intake approach is to make the patients feel as though we have parted the waters for them. This model can become the healthcare experience of young Black MSM everywhere if we work with referral sites to improve the likelihood of actually connecting with that patient on the day of diagnosis. If we apply that wealth of information that we have amassed, and especially in this room, about Black MSM, to revamp that intake process, that initial contact, I think that would be extremely important for having successes, right? We want to help build intake processes that demonstrate in words and actions a clear, bold, emphatic yes to the questions, is my life worth protecting? Is my life worth saving? We also want to strongly support and create processes that allow for day of diagnosis treatment when your patient is willing. I am so excited to be part of this program today and so excited to bring information about this beautiful program back to my home campus. And I definitely at this point want to introduce your next speaker, Justin T. Rush from the True Colors Fund.
Hello, everyone. I'm going to close this. I want to introduce myself. My name is Justin Rush, and I currently work as the Director of Public Policy at the True Colors Fund, which diligently works to prevent and end LGBTQ youth homelessness. And here we have someone who I'll refer to as James. And behind those quiet eyes lies a story of persistence, resistance, pain, loneliness, and depression. You see, he's just trying to live, to be, to exist, but everywhere he goes, he hears you're nothing. You're not good enough, and you never will be. You sound white. Why do you talk like that? You're an Oreo, a punk, a sissy. Each individual statement of oppression leaves him feeling like less than the person that he was before. Every word lands with the swiftness and the sting of a blow to the chest. Long story short, I know James's story intimately. I am him. He is me. You see, growing up in Columbus, Mississippi, which is only about 2 hours northeast of where we stand today, as a Black queer youth in the late 80s and 90s, there was no playbook for my existence. Each and every single day was like walking through a minefield as a little Black gay boy who liked to go to school and read books, play instruments, sing. And whether it was the discrimination that I faced due to being Black, the racism, or the darker hue of my skin, the colorism, or the fact that I never quite perfectly fit into this notion and idea of what a boy was supposed to be, by the age of 11, I was withering on the vine. I was lonely. I was depressed. I was turning inward. But thankfully, I was privileged to have a family that poured their love into me and actively worked to provide me with the tools that I needed to be able to learn and grow and become the person that I was supposed to be. This included things like taking me to piano lessons, taking me to Taekwondo classes so I could learn how to protect myself, and taking me along to political rallies and volunteer opportunities. And it was there in 1997, in Jeffrey Rupp's first mayoral campaign of Columbus, Mississippi, that I realized the power of grassroots mobilization and advocacy. And it turned out that advocacy was my saving grace, giving me a place to channel my hurt, my fear, my frustration, my otherness. And I learned that working to make change gave me a sense of control and hope. And ultimately, I found the community that I needed. And I felt the power of what can truly be accomplished when we all come together to fight for a common goal. It was through these formative years of my advocacy that I learned that, one, you have to stay engaged, and you have to take action on the issues that matter to you most. And even if change is slow, that your advocacy matters, that you matter. Two, you absolutely must stay informed. As my colleague Greg Millett has said before me, being informed is how you build and remain a credible voice. Three, you have to know the power of storytelling and telling your own story and perfect it, and know and believe that personal stories have the ability to transform very heady and nebulous topics that can easily be dismissed into experiences that can never be denied. I also learned that to make a difference, we need to address the societal factors that impact health. And these range from a person's family of origin to the society in which they reside. For example, within the family of origin, the individual has experiences that relates to socioeconomic status, belief systems, emotional and intellectual resources, and sometimes trauma. Our families of origin are impacted by the communities in which they rest. These communities, too, vary in economic opportunities, belief systems, and resources, or lack thereof. Finally, communities are shaped by larger societal factors, including institutional racism, structures, governance, and policy. And through my early years in advocacy, it became obvious to me that the interplay between poverty, homelessness, and homophobia can and has had a dramatic impact on our communities. Through the experience of working with youth experiencing homelessness, I have been able to see the connection between health and social issues clearly. I have seen the impact that experiencing homelessness can have on one's mental and behavioral health and access to care, and more importantly, the intersections that cross health, HIV, and homelessness are evident. People with mental health and behavioral health issues are much more vulnerable to experiencing homelessness. And experiencing homelessness can have a dramatic impact on one's personal, physical, and mental health. Additionally, the living conditions of those experiencing homelessness make people more susceptible to communicable diseases, in part because people who experience homelessness are much less likely to have access to health care. And through my work, it has become even more clear that the stigma that LGBTQ youth face within their families, their schools, and their communities has a dramatic impact on their lives, and this includes their housing. For example, of the 1.6 million youth experiencing homelessness at any given point in the country, up to 40% identify as LGBTQ. 30% of those youth state that they have engaged in sex work in order to receive their basic needs: food, clothing, housing. And homeless youth are 2 to 10 times more likely to acquire HIV, with homeless youth stating that they feel that they are 50% more likely and very likely to someday test positive for HIV. It is through all of my lessons and personal experiences that it's become clear that in order to improve the health of LGBTQ youth and Black MSM, that we have to address the intersections between HIV and homelessness. We have to do more to work across sectors. And at the True Colors Fund, I recognize that I can play a role in ending HIV. And where you are in HIV, you have to recognize that you too can play a role in preventing and ending youth homelessness. And it'll take much more than just you and I. It'll take all sectors of our society, government, community, and private industry to end the HIV epidemic and the youth homelessness epidemic. By working together, we will improve the health of all LGBTQ youth. And by working together, we have to start off by strategically identifying issues that are pertinent to both realms. There are obvious issues like Medicaid and expansion and securing access to mental health care for all, but there are also many more issues that impact both HIV and the LGBTQ youth homelessness realm, such as ID access, where over and over and over in the work that I have done, I have heard that if I don't have an ID, then I don't exist. And if I don't exist, then I can't access my meds, or access housing, or go to school, or seek employment. And if I can't go to school or seek employment, then I'm out on the streets. This example clearly illustrates that there are many opportunities for collaborative advocacy. Indeed, we can build strategic partnerships, communities, and intersectional movements, and consolidate power by having intersectional conversations, often and everywhere possible. We have to invite others to our table and ask to join theirs as well. We have to strategize collectively. We have to be aware of the variations of privilege and oppression, and sometimes we have to leave the shade at home and support one another across sectors. Let me share one of the best examples that I have of working across sectors, and it is the work that is being done around HIV and housing, furthering the notion that housing is HIV prevention. A shining example of working across sectors in the work of furthering that housing is HIV prevention in states is in New York, where housing and HIV advocates have worked together on a plan to end the HIV epidemic. Together, they realized that without stable housing, people living with HIV have difficulty accessing and staying in care, and they also have difficulty adhering to their treatment. Advocates in this movement partnered with the governor to create approaches to reduce homelessness, and as a result, they passed legislation to implement a 30% rent cap for an affordable housing project. Moving forward, I want to urge every attendee here to think about what other intersections and opportunities exist, and what would allow us to advance the health of our community. From there, there's nothing but to act. We as a community have to know what is happening locally, as well as what is going on at the states and the federal levels. We have to know how changes in policy impact and affect our community, and more importantly, we have to show up to the fight. If you don't know your local city council member, your local city alderman, your state assembly member, your state senator, or more importantly, if they don't know you by name, then you simply are not doing enough. All politics are local, and every state and every year within states legislators are passing hundreds of pieces of legislation that impact all of our lives. You simply can't be outraged if you don't show up and hold our policymakers and our decision makers accountable. And last but not least, we must create a grassroots movement of Black LGBTQ advocates armed with a for us, by us policy agenda that will help us fight and end homelessness within our community. Thank you.
Can we say for us? For us. By us. By us. For us. For us. By us. By us. Thank you, Greg, Roberta, and Justin. Help me celebrate them. Superheroes cannot do it without teamwork, and neither can we. So think about your good girlfriend circles, or your Judy circles, or your medical team. Think about the people that you call to go demonstrate with, or to go protest with, or go to march with. The girls that you get together to go and organize. We all count, and we are needed to end the epidemic. What you think about that? And so as we close today, think about the power that you come to this space with and what you have to go home to fight. As superheroes, we've come to this space to fight HIV, yes, of course. But we also come to this space to fight youth homelessness. Many of us are fighting voter oppression in our communities. Many of us come to this space fighting for police accountability in our local communities. Many of us are fighting for fresh produce in our communities, for elderly and low-income individuals. Many of us are fighting for affordable health care in our communities. And to be honest with you, many of us are just fighting to save ourselves. And so whatever you bring to this table while you're here at this conference, let's do it collectively. Let's bring our power together, and let's figure out how to come up with a collective solution. Thank you so much.